All right, we're recording and I will begin here in a moment. Here we go. 3, 2, 1. Hello, everyone, and welcome to the Heartland Daily podcast, where we are going to be talking about news in healthcare and all the developments over the last couple of weeks, as we do a few times each month. My name is AnneMarie Schieber. I'm the managing editor of Healthcare News, and I'm joined by Devon Herrick, who is a healthcare economist and writes for the Goodman Institute Healthcare blog. And like I said, a couple of times each month, we pull together from hundreds of healthcare news developments, many things going on, especially now with the budget bill still being negotiated. But we have a lot to talk about, so I'm not going to waste much more time. Good to see you, Devon. How you doing?
Well, I'm doing well. Good to see you.
We were talking about the heat. It's excruciatingly hot as we record throughout the entire country. Devon lives in Texas, where he's quite used to it, but it's throwing everybody in the Midwest and other parts, the East Coast, for a loop. So stay careful because it can be a health threat as well, hot temperatures. But in any case, we know that things are heating up on Capitol Hill at the Senate, where they're negotiating the big, beautiful bill. And the idea is to get this bill. It got through the House with not a whole lot of fanfare because a lot of stuff has been stripped. I know a lot of healthcare reformers were underwhelmed by what had come out of the healthcare part of it, especially in Medicaid. But anyway, it's now in the hands of the U.S. Senate. And every day goes by. President Trump wants this on his desk by July 4th. That's in 10 days. And every day, it seems like they strip out more and more from this bill. I'm waiting to get up one day and it says, lawmakers have decided that there's not enough reform in the bill. And they decided to go all out and give everybody a health savings account. And we give cash accounts to people in Medicaid, so they'll use it less, whatever. But we're not getting anything like that. This article was last week. It was a bad bill made worse. I don't know if we can pop that up, Ian. This was in Becker's Hospital Review. And it's just underlying, this is actually good news for reformers because there is a lot of waste and fraud in Medicaid. Medicaid is a system run primarily by managed care. And my goodness, it covers 1 in 5 people in the country. It's kind of our form of socialized medicine. And there aren't a whole lot of incentives to keep people out of the hospital. We have people in Medicaid still overusing hospital ERs, which are very expensive. And why do they do that? Because they can't get primary care. Why can't they get primary care? Well, for a variety of reasons. The reimbursements, there are too many people, not enough providers, not enough doctors. And so the fallback, of course, is going to the hospital ER. Hospitals love this, of course, because it drives more revenue their way. But there was really a lot of hope with the Republicans, one party controlling all the chambers and the White House, that we were going to see some meaningful healthcare reform. And that looks like not to be the case. What I read last week was the Senate Finance Committee, which is looking at these reforms, dropped health savings accounts. And under the House provision, we were going to get 20 more million people who would be eligible for HSAs. That would be a 50% expansion. Now it's looking like the Senate Finance Committee is going to scrap any expansion of HSAs, which is really very disappointing. I mean, even with the little bit that we got under the House bill, and what it was going to do was redefine or expand the definition of who could qualify for an HSA. Right now, you have to be in a high deductible healthcare plan to get one. And you only get you can contribute just a little bit of an amount. And then there are very strict regulations on what you can spend the money on. Under the House bill, they expanded that definition. They were going to allow people in Medicare Part A, which is the hospitalization of Medicare, to have an HSA. They were going to expand the number of items that you could use your HSA on. That would include direct primary care membership up to a certain point, gym membership, over-the-counter drugs, medical travel. And then there was a reimbursement provision, so you could sign up for an HSA after you get the care. All these things look like they're going to be stripped from the Senate bill. I don't know what's going to happen. Are you optimistic that there is going to be a healthcare reform part of this big, beautiful bill on President Trump's package in 10 days, Devon?
Well, I don't know if there'll be in 10 days. I'm afraid that too much is getting watered down. You're absolutely right. I mean, HSAs, I have an HSA, but I can't contribute to it because the rules are so rigid that even when I had a high deductible plan, it didn't necessarily qualify because of very, rigid rules written by the, Treasury, years ago. Yeah, it would really be nice if they would relax some of those. And there's a lot of very good items in the, the big, beautiful bill. I mean, work requirements for Medicaid enrollees for adults is a no-brainer. Why would we give people free health care who aren't even trying to work? Doing away with phasing out provider taxes. And for those who don't know, it's a money laundering gimmick states use where they pay providers a little extra, then they tax providers, then they use that tax to pay for the state's share of their Medicaid matching requirement. So essentially, it's a way to shove all the cost or much more of the cost on federal taxpayers. So allowing the state to be wasteful and to be generous. Well, we can have all kinds of program. We can cover all kinds of, and it's been a loophole for years. And it's such an entrenched loophole that hospitals and public health advocates are screaming bloody murder at the thought that we might actually take away a loophole that was designed to circumvent matching requirements.
Absolutely. And even the work requirement may be scrapped. They're already balking at this, and they want to expand the on-ramp to something like 18 months. They want to give people a year and a half to get, and the provisions for work are pretty limited. It's like 20 hours a month. Or I don't know. And then there are all kinds of exceptions that you don't have to get work, and you could even be in a training program. It just is a way to give people an opportunity to value the healthcare that they get. When you give it to them for free, they don't care. And that's when the misuse happens, the waste. They'll call up a doctor, make an appointment, not show up because there's no penalty. And the hope was that this work requirement would allow people to start valuing Medicaid, which they don't already. We have expanded it to leaps and bounds over the last 10 years. And it's basically become the US's form of socialized medicine.
Yeah, and that's kind of why whenever people talk about, they advocate Medicare for all, I call it Medicaid for all, because you really can't do Medicare for all at the current. It'd be the similar to how Medicaid is run. But yeah, it's kind of interesting. You talk about a lot of enrollees don't really value the care, or at least the concept of coverage. If you talk to doctors, a lot of doctors do not want to take Medicare or Medicaid. And one of the reasons, it isn't just the low reimbursements, it's the no-shows.
Right.
I forget what the percentage is. Years ago, it was something like 1 in 4 of appointments for Medicaid enrollees didn't show up and didn't call and didn't cancel, and
Right. Well, there's all kinds of problems with it. And when you give something to somebody for free, they're not going to value it and they're going to waste it. Now, there's all kinds of fear mongering, and it's starting to have an impact on people and public opinion. Ian, if we can pop up this headline I saw a couple of weeks ago, projected effects of proposed cuts in federal Medicaid expenditures. This was a study that came out. Wow, the timing is just perfect, right? In the Annals of Internal Medicine. And this study used a computer model and determined that the cuts that are being proposed will lead to 16,642 premature deaths. Now, how you come up with such a figure is astonishing to me. This is all guesswork. And, aside from the other ways that people can die besides, not getting enough Medicaid, car accidents, whatever, violence, there are just so many ways, that we do have real life examples. And I want to show this because in the Cato Institute, back in February, I had a phenomenal panel. And if you ever want to get educated about this, watch this 3-hour panel discussion on Medicaid. And there was a professor there from George Mason University who came up with 4 very famous studies. I don't know, are we able to, well, I just kind of want to highlight them. But anyway, I'm going to pop up some of these studies. So this was a professor at George Mason by the name of Robin Hanson. And he talked about the real life experiences with cutting Medicaid and what impact that has on overall health. And it just isn't established. We've got 4 famous, very big real life experiments of what happened when we cut government health care. And the first one, of course, is the famous one, the Oregon Medicaid experiment. You remember that one, Devon, right? This was a couple decades ago, where they had a lottery. They had a limit on who could sign up for Medicaid. And it provided an opportunity to see what the outcome would be on the people that didn't win the lottery and couldn't sign up for Medicaid. And it turned out the people who couldn't get into Medicaid actually had better health outcomes than Medicaid, the ones who were enrolled in it, right? That's just stunning right there. There was another.
It was Amy Finkelstein, I think, was part of that research. And what was important was these were motivated people. These weren't just, random people who didn't care. These are people that wanted to be in Medicaid and actually entered the lottery. And so they were the most likely to make a difference. And there essentially was no difference. They were getting similar amounts of care. They were going to the doctor similar amounts of time. They were getting their chronic needs met, roughly equal, or, give or take. And it was, people were astonished at how little a difference it actually did make.
Yeah. Well,
but these studies like this, 16,000 premature deaths. Well, you can't find the bodies. There are no bodies. People can be pretty resilient. And if you look at the 2 of the co-authors of this journal article, it's, Woolhandler and Himmelstein. They're famous for winning a national health program. They're part of their major players in that organization. And every few years, they are probably more often come out with yet another study that purports to show that it'd be all wonderful, rainbows and perfect health if we had a national health program.
Well, I bet the funding for that study came up awfully quickly. I'm sure the hospitals, insurance, managed care companies were more than happy to get the money, the checks written to get that study done just in time. It's stunning. When you don't have health insurance, what do? You're very careful, right? You do things differently. You make sure when you're starting to get sick, you take care of it right away. And one of the biggest problems is, when you've got carte blanche healthcare and you feel yourself, cold coming on or whatever, or maybe you injure yourself and you don't pay attention to it, you don't let it sit. You take care of it right away so it doesn't get worse. And if you've got Medicaid that's going to pay for anything, no matter what your behavior is, whatever you do, you're just not going to do the diligence that people without health coverage will do to stay healthier. And that's why these studies show these amazing outcomes when people are not automatically enrolled in these programs. Robin Hanson also mentioned another one. It was another experiment in India. something like 52,000 rural Indians had cheap access to hospital insurance. And those who bought more used it more. They discovered they were in the hospital more often. And the people who got free insurance, and there was no significant difference in the health outcome. There was another one not too long ago in 2019 called the U.S. Taxpayer Experiment. And I'm just reading my notes from that panel. They sent a letter to people warning them if they didn't buy insurance that they would face a penalty. And 500,000 people over the next 2 years, those who got the letter bought, and 23 more months of insurance. And the mortality rate of people being in insurance was not that impressive. There wasn't a whole lot. It just basically they ended up having, 6/100% lower mortality with just one extra week of insurance. So, we do have these randomized experiments, these that show that really, we don't have to be paying for all of this stuff. The reason it takes 2 months to get a big, beautiful bill together is because we spend so much money in the government. We manage everything. It shouldn't be like this. We shouldn't even be debating this, right? Crazy.
Well, if you think about it, it's the extra doctor visit is, for most people, is not the difference between life and death. The difference between life and death has to do with years and years of behaviors and a lot of genetics, and suggesting that 16,000 plus people would die if they don't have Medicaid is really just, it's just conjecture. It's not. The same thing was said years ago. If we don't cover the uninsured with Obamacare, we'll have X number of people dying. But there was never any, there was never any bodies show.
Right.
You can dig through medical records and you can find one person who should have gone to the doctor, but they didn't. Well, it's pretty rare that you're going to find one intervention that is so life-saving that you could literally count 16,000 people dying prematurely. And we don't even know what that is. Is that a week early, a day early, an hour early?
Well, I guess we'll see in 10 days. The little bit we got in the House will probably be completely stripped out. Who knows? I don't know. I just can't make any guesses right now. We'll just have to wait until July 4th if a bill does get on President Trump's desk, and we'll see how earth-shattering or not earth-shattering it will be. I should mention there are 2 bills that are not part of the big, beautiful bill that are being introduced separately, which are really good reforms. We've tried them before, but one of them is to address some of the problems with Medicare Advantage. Mm-hmm. And this bill introduced by Senator Cassidy, the No Upcode Act. I don't know if we can pop that up on the screen, Ian. Do you see that there? Nope. There it is. Okay. So 2 senators, Merkley from Oregon, introduced the No Upcode Act. Now, Medicare Advantage, maybe Devon, you can explain why Medicare Advantage is of interest to taxpayers and to really anybody. It is kind of because it has a private provision to it. Can you tell why we need to protect Medicare Advantage?
Well, Medicare Advantage are the private insurance options that are increasingly popular for seniors to enroll in instead of what's called traditional Medicare. United Health Group, Humana, a few other, it's all major companies you've heard of. And the reason why they're popular, I think more than half of seniors in Medicare are actually enrolled in a private plan. And they're popular because in many cases they give more benefits than traditional Medicare. Where this bill tries to address is that some of the insurance companies have essentially they hire a nurse practitioner to go to an enrollee's house and they interview them and they try to find out every single item that they possibly could have wrong with them. And then that allows them to charge the government more, because pre-existing conditions, it's called the risk adjustment. Well, the research has shown that in many cases, an insurer has been paid more for a given senior, but hasn't actually treated any of those items that supposedly warranted a higher payment or subsidy. And so what Senator Cassidy is trying to do is close the loophole where insurance companies that are otherwise providing a good service to seniors don't charge the government more for care they're not actually providing. So it's trying to close a loophole on the risk adjustment mechanism that some insurance companies are using to boost their subsidies from taxpayers.
Now, people like John Goodman, who is our boss, talks about Medicare Advantage quite a bit. And what the beauty of it is you now have private companies competing for the sickest people. So in a perfect world, you would have very good risk adjustment models done. And that just really hasn't happened. What happened is these managed care companies learned to game the system to get more money without really providing better care. And so this bill may be a good thing because it'll get maybe some of these companies to get more on the same page, but there are 4 provisions in this bill. So they're going to need now 2 years of diagnostic data for the risk adjustment model. They're going to limit the ability of what medical conditions will be covered to determine the cost of care. Medicare will only pay for ailments that are related to the risk. So I can't imagine what was going on before, whether they were covering everything under the sun just because you happen to be in a higher risk pool. But there were some problems with it. And like many of these programs that try to address healthcare from a free market perspective, they're going to be growing pains. And we have to figure out the best possible way. I'm encouraged by this bill. I don't know what's going to happen with it. I want to pop up the next thing because we have had bills in the past on another important issue involving, this is not just Medicare, but hospitals in general. It's called site neutral payments. Well, actually, it is Medicare. And if we can pop up the link that shows Same Care, Lower Cost Act. All right, this was a bill that was introduced and to eliminate Senator Kennedy introduced this bill, Same Care, Lower Cost Act. This is to implement site neutral payments. So for people who don't know, Medicare pays providers linked to a hospital more money for certain procedures. And hospitals, of course, love this. That's why you see every hospital satellite office in my community, they're all over the place. We have a hospital like every hospital operation, like every half mile, it seems. And, these are nonprofit organizations, right? So they don't pay property tax to the local entities. And then they compete with private independent doctors, right? So they get all this tax advantage. They get more money from Medicare. And so how is a private independent provider supposed to compete with this? They can't. They either have to join the hospital or get out of the business.
And that's exactly the problem is that the independent providers, whether it's oncology or just primary care, cardiology, it's like the hospital comes to them and says, if you'll sell to us, we'll employ you. You can work 40 hours a week and we'll pay you what you're already getting paid because we'll get paid a lot more. And so then, of course, a senior or Medicare enrollee goes to their regular doctor they've been seeing for years. And then they discover, wait, what's this extra fee? Well, why is there a facilities fee on my bill? Because seniors have cost sharing in many cases. And it's like, this office is now owned by the hospital. And so you came to a hospital. You did not go to an independent doctor. And it's really a scam. Okay. It
is.
If I go to my doctor is not the hospital. If my hospital owns a physician practice, they should not be compensated an extra fee because the hospital owns it. I mean, and really, I mean, an example I think I used today when I wrote on the Goodman Healthcare blog was my wife almost got a CT scan at a hospital, $3,000. Her share was
Hmm.
$2,700. The same scan was 403 somewhere else.
Yeah.
And now this was not a Medicare pay, but Medicare would have done a similar. Medicare would have paid the hospital, several thousand compared to several hundred elsewhere, and that's just ridiculous. Why?
Right.
Why? I mean, what incentive do hospitals have to compete on efficiency if everything they do, they're automatically paid more than the freestanding independent place up the street that it is not part of a hospital? And like you said, it's a unfair advantage. It allows the hospitals a big bonus that they don't deserve, and it forces taxpayers and consumers to
Yeah.
pay more for care that they couldn't avoid. And we can't avoid it because the hospitals are buying up all of our doctors for that
Yeah.
reason.
And let's face it, it's not an endless system. We have a fixed number of providers, right? So when a hospital gets so much money from the government to provide a service, why would that hospital want to charge or offer it to a direct payer without getting the same amount, right? So this drives up direct payment from private people, not in those government plans, and makes it very hard for them to get healthcare services. So it has a big impact, like a chain reaction to these policies, and it needs to go. The hospitals are not going to go quietly. They have fought these bills. We've had several proposals over last couple of terms sessions, and they go nowhere because the hospitals just fight them very fiercely. So let's hope, we have a different makeup now in this session, and maybe it will get a little traction, and we'll see. I want to move on to the next topic, which is getting a lot of reaction. And I'll tell you, I don't want to get into whether vaccines are good or not, but vaccines certainly have gotten a lot of attention since COVID and the mRNA shots. So HHS Secretary Robert F. Kennedy Jr. Has replaced his entire vaccine committee. Now, there's 17 people on this committee, and he wiped out the entire one. And the media is going ballistic, describing these things as purging, sacking, replacing it with panel members who are vaccine critics and misinformation, and everybody is just going crazy. There's an article in Fierce Healthcare, which I thought was kind of telling what's going to happen. So I just want to make one quick point. Biden did the same thing, okay? He appointed every member of this panel. And I don't recall screaming headlines about who he picked. He picked people who were very pro-vaccine. That's politics. That's what happens when you win an election. You get to appoint people in the administration. And that's exactly what Trump is doing. So I don't know why they are so shocked by this. This committee is really important because it makes recommendations for shots, especially for children. And a lot of people depend on this CDC list about what they should require for people to either get employment or be admitted into a school or a university. And really, it strips away informed consent from people. If you try not to, let's say you choose not to get certain vaccines for your children, good luck getting them into a school program. So what we're going to have are now very different perspectives on this committee, and we may change that schedule. Who knows? We know, how Kennedy feels about vaccines and some of the people who are on the panel. But I mean, if you don't like it, I guess there's another election in 3 years. So what are you going to do?
Well, it's interesting about vaccines, and I haven't really looked at the background of each of the 17 people that were dismissed. But by default, generally, they're going to be people who have ties to the industry. It's really hard to get away from that. It's going to be people that are pro-vaccine. And, it would be kind of odd not to have someone knowledgeable about vaccines on the committee or on the advisory panel. So it's kind of a catch-22. I mean, in many cases, you don't want the bias, but at the same time, it's just built into the system. So I think what Kennedy was partly trying to do was to get rid of some of the people that were shills for the industry, receiving payments from the industry. Are you really unbiased if a good chunk of your income is consulting fees? And in many cases, the consulting fees are really just payments to make you loyal.
Right.
Unfortunately, that happens too much. And another aspect of vaccines is that I've often thought about is, I mean, we all can agree that vaccines have a benefit to society. But if I have my way, it's like, I want you to get the vaccine so we have the herd immunity, but that way I don't have to get it. And so there's always going to be a little bit of, what economists call free riders.
Well, yeah. But again,
because we have different values, different views, different risk tolerance. So
yeah.
So it's a controversial issue whether you're pro or anti-vaccine, simply because
Right.
you can be anti-vaccine but still want someone else to get it simply so you don't have to.
Well, I think vaccines should be available. I think what people are really upset about is when they're mandated to get things that they don't want to do. And we certainly do that for children. And
Yeah.
I know the government will set a standard that everyone wants to use. What I think we should do is maybe have private organizations make lists of recommended vaccines and let the free market take it over.
Mhm.
And if a particular school district wants to use organization A's list of vaccines, boy, we should have school
Mhm.
choice too on this. But if a parent doesn't want to abide by that, let them go to a different place to educate their children. I think there needs to be more choice out there. And certainly we have the technology now with AI and all kinds of technology now to be able to show some of the side effects of vaccines, who they're appropriate for, what they do, and whatever. And I think, the more information, the more technology we have, the better decision making we can do. But again, I don't want to strip people of individual choice, and we should
Mhm.
provide people with as much information as possible and let them choose accordingly. And that's originally what the CDC was supposed to do in the first place, right? Give people the information, let them make the decisions. But we've gotten so far from that. And of course, the lobbying and the special interests and
Yeah.
getting people who are really cronies of the industry on these panels so they can make a recommendation to sell drugs. That's what we got to get. And I think Kennedy
Well,
is
yeah,
number one
there's all
priority.
this pressure to, in many cases, they're not looking at how little we can do. They're looking at, that they want more. I mean, even for my pet, my dog, I took my dog to the vet a while back, and they said, and she got a rabies vaccine. And they said, well, this is a 1-year vaccine. I said, oh, really? What's the difference? Well, if you'd come in 2 weeks earlier before the previous one expired, we could have given you a 3-year tag. But the state law says that since it was expired by 2 weeks, you got to get it again next year. It's like, well, that's ridiculous.
Well,
I'm sure it's the same for people, I mean, it's if you don't, we should get it more often than you need it just to be on the safe side.
Well, I know. And the vets, I have a cat and I've been through this, and they want you to get all kinds of expensive shots for your cat. My cat was like 20 years old, and there was no way I was going to get my cat, who's an indoor cat. My cat just passed away, but a rabies vaccine, so again, I just don't understand. I think you got to question it, and it should be really up to the pet owner or the parent of what they want to do to their bodies. So we will see. I want to get to the next three items. We've got a couple more things to talk about, and we're getting tight on time. I want to mention this thing. Matt Dean, who had done a lot of work for the Heartland Institute in healthcare. He's a former Minnesota legislator, and he wrote this piece for the American Experiment in Minnesota. Can we pop that up on moms and Medicaid? Minnesota is encouraging, and are you able to pop up that link? The American Experiment bill incentivizes. Nope, that's before that. Not that one. We're going to talk about that in a minute. Excellent points. Okay, now let's take that one down. We're going to talk about that in a little bit. Matt Dean wrote this here. Let's take that down. We're going to talk. Yeah. Nope. Okay. We'll hold on to that because we're going to talk about that in a minute. Minnesota legislators recently passed a bill that will provide home birth for people in Medicaid. And they basically incentivize home births because they are allowing Medicaid to pay for equipment and whatever's necessary to have a successful home birth. Now, if you wanted a home birth and decided, gee, if I go to the hospital, I'm not going to take anything home, but boy, I can probably get a bed. I can probably get all these nice things when I have a home birth. It's incentivizing home birth. And what we're talking about is the Medicaid population and women who may be at high risk. And we shouldn't be encouraging people to stay out of the hospital for high risk pregnancies. We have, years ago when few babies were born in hospitals, we had very high childbirth death rates. And it was because we didn't have the technology and the critical care that's necessary sometimes when deliveries don't go as planned. I think Matt Dean's point is they're using the idea that this population, so home births have become very popular among a very affluent crowd. And we're applying the same principles to an at-risk crowd. And we could probably be getting ourselves into trouble under this. Mm-hmm. And I just don't think it's a very good idea. Will you have any thoughts on this?
Oh, yeah. John Goodman, who, like you said, is our boss, wrote about this years ago that Dallas Parkland Memorial Hospital literally wrote the book about, how to safely deliver babies from high-risk pregnancies, poor people. I mean, literally, years ago, if there was ever a public hospital, they deliver more babies than I think any other hospital in the nation.
Yeah.
And they created the method. And if you go to Parkland, I really think it would probably be cheaper for because they deliver a lot of Medicaid babies. It's probably actually cheaper for Medicaid to pay for someone to go to Parkland, where it is they're extremely good at it, compared to a home birth of someone who's poor. I may not even have a home. I mean, you may be in someone else's house. You may be sharing, a bedroom in your parents' or grandparents' house. It doesn't sound to me like it's well thought through to subsidize home births. But what, of course, does work is follow Parkland's rule book that they have spent 50 years perfecting. So yeah, right. That's quite interesting that they are subsidizing and actually incentivizing home births. I could see maybe birthing centers, next to the hospital in case something goes wrong, but it just doesn't seem well thought through to subsidize home births.
Should be patient safety first, right? That should be the criteria, and then cost efficiency. And I'm for both of those. I don't think that's the incentive behind this bill. It's to give people an optional so-called better experience, and that should not be the reason to do it. One of the things that Dean pointed out in his article was that a 2022 Medicaid study in Minnesota found that Black women were 2.3 times more likely to die from a childbirth-related event than white women. And given that 72.9% of all pregnant Black women are served by Medicaid in Minnesota, having home births is probably not a very smart thing or encouraging.
Yeah, really.
So I guess this bill is passed, it's been signed, and it's going to happen. Also, it's encouraging, we have physicians in hospitals, right, who are trained in critical care issues, especially involving deliveries. When you're doing a home birth, you're not going to get that kind of training from the person who's assisting with the home birth. You're going to get a doula or a midwife, and they just don't have that background. And before you know it, it's going to be the ambulance, rush the baby to the hospital. And I would hate to think the tragedy that could ensue. So maybe they'll rethink this. Minnesota is the only state that's doing this. So we will see how that works out. The next topic I want to jump onto, which was an eye-opening op-ed in the Wall Street Journal a couple of weeks ago. If we could pop that up. This was incredible. Santa Clara University's crazy idea of human sexuality. Now, this was written by a grad student, and she's trying to get her degree in family therapy, I just want to pop it up here so I can read it and not misquote it. But she is a student at Santa Clara University in California, and she is training to be a marriage and family therapist. And in California, you have to be licensed to do that, and you have to get certain amount of graduate requirements. And one of the courses she was had to take was this course on human sexuality. Okay, fair enough, right? That issue is probably going to come up in marriage counseling. But the content in this class, and I'm not going to read it out loud, but it was absolutely stunning, the things that this class was discussing. It wasn't, to me, academic in any way. It was more pornographic than anything. And she requested to opt out of the class. Now, apparently there's some Muslim students there that didn't want to take this class either. And the hospital and the university had to make an accommodation for them. She is short of getting her degree. She paid this money and they won't give her an option. And her degree is in jeopardy, apparently. But what was really striking about this was the content of this class seemed very political. And what she was complaining about in this op-ed is that therapists who work with very fragile people, we know that we have a mental health crisis in this country. And usually it's very hard to find a psychiatrist or a psychologist. So you go to a person who has a graduate degree. And there is a wide scope of degrees out there. And people really don't know what they're getting into. They don't know how their clinician was trained. But some of them, in the past, it was always believed that there would be neutrality in the clinical setting. And that's not what's going on these days. Now, I want to pop up. I did a little research. I wrote about this. I tried to reach out to this student, but I didn't hear back from her, and I don't expect to. There was another article that came out a few days later. And Ian, if we can pop that up, it's called Neutrality No Longer an Option. It's in a publication called Mad in America. And this is written by a therapist who said the idea that politically neutral therapy rooms, clinical settings, is outdated, and that we should pretty much affirm and validate people's faulty or, problematic thinking. If you're having issues with mental health, maybe there's some distortions that you're trying to come to grips with. But, basically, this article was just stunning to me. Political violence is family violence. And we talked about this in the past, too, that there is a push to do alienation treatment, alienate people from their families because their families are too dangerous, they're too patriarchal, I don't know. What do you think about this, Devon?
Well, the mental health counseling industry, not unlike the public health industry, tends to be left leaning because, by default, they think that there needs to be more taxpayer funds. And there is a shortage of counselors, and a lot of them will not take insurance or will not participate in public programs simply because reimbursement. And it's probably also easier to counsel wealthier cash paying clients that just have garden variety angst compared to real, serious problems. But yeah, there's definitely a bias in the industry, and I don't think there's much of a way to get out of that. Simply, it's because you self-opt. If you want to go into counseling, the odds are you're probably, more. I mean, not necessarily always, but quite often, the ones people I've met, if they go in public health, they believe in public finance of healthcare. If you go into counseling, you probably believe the government should do more to fund mental health care. So it's not an easy, and it is, there's a fine line with how do I be unbiased and how do I counsel all my clients, patients in an unbiased manner versus how do I indoctrinate them and let them know that they voted for Trump and he's the devil. It's
Right.
I think a lot of the counselors that are left leaning, they really feel that way, and they can't help it. They can't help but try to be politically biased and influence people's thinking.
Well, again, I think it's all over the map, and you're talking about people who are very fragile, and they go in there with a open mind thinking that they're going to get help dealing with their issues. And if you've got a counselor who has an agenda and wants to promote the idea that you're being oppressed or victimized, or you need to cut off contact with everyone in your circle, that to me is problematic, and there's no oversight. And we have to ask ourselves, why is the mental health crisis not going away? And I would say a lot of this training has been occurring along with the culture over the last 5 to 10 years. And maybe we're starting to see that reflected in our current patient population. Anyway, just something to be watchful for. If you're going to need a therapist, I would just make sure I totally understood where they were coming from. Maybe ask for some articles that they published to see what their bias might be. They're grad students, so they do write, and they should have some of their content out there. And I hope somebody comes up with a list that clients could ask therapists before they sock a whole lot of money into something that could even be, damaging to them even more than they are struggling with right now. So anyway, just my thoughts. All right. The last topic is something you blogged about, Devon. I don't know about you, but I am hearing about a lot of cancer diagnoses. And maybe that's because of my age. But, everybody, we hear in the headlines all the time what causes cancer, what's a correlation to cancer. Tell us what you came up with.
Well, the premise of the article was that the biggest risk factor for cancer is not what you think. It's not overeating, obesity, smoking, drinking. It's age. And we kind of always knew that. But it's just kind of bringing home an important point that, you can do things to lower your risk. You can watch what you eat. You can maintain a healthy lifestyle, not smoke, drink in moderation or not at all. But the biggest common denominator of who gets cancer is, well, what is your age? And what's interesting, let me look and see if I can find it here. Here we go. If you're between the age of 0 and 49, your chances of getting cancer are like 3%. That's 1 in 29. But if you're between 50 and 64, your chance of getting cancer rises to 11%. And so if you're 65 to 84, your likelihood of getting some kind of cancer is roughly a third.
Wow.
And so between 0 to your 80s or beyond, about 4 in 10 Americans will get some type of cancer. But the biggest correlation is really age. And you say, well, what about, so does that mean I can smoke and drink and do whatever? Well, it may be the damage from smoking and drinking for 50, 60, 70 years that does it. So yeah, you can still lower your risk, and you should, but at the same time, cancer is primarily a disease of old age. So,
Right.
if you knew I'd live this long, I would have taken better care of myself, I guess. That's the old
Well,
joke goes.
what do they say? It's never too soon to stop smoking, that you will always start buying back your life the moment you stop smoking for good. My father passed away from lung cancer and was a chain smoker for many, many years back in the 60s when just about everybody was smoking. And when he retired, he tried multiple times to quit. And finally he retired and said, that's it. I'm not doing it. And that was the most successful attempt. He quit smoking for 10 years. Now he died at age 79, but perhaps it might have been sooner had he not taken that chance. You just don't know. The other thing about age is we are living longer, right? So we're going to see more cancer
Exactly.
diagnoses, and we can detect it better than we did decades ago. So that may be another factor. The other thing too is how you treat it. So, what do they say? There are 3 ways to treat cancer. You poison the body, you burn it, or you cut it out. The surgery, chemo, and radiation. Those are the 3 common standard treatments for cancer. And when an oncologist comes into the scene, they have to determine what the life expectancy is of that person. Now, if somebody is really, really young, you're not going to try a very radical, extreme treatment that you think is going to kill them in 10 years, right? You're going to be somewhat cautious. But when somebody is older, you may have more opportunity to do that. You don't care what's going to happen to them maybe 20 years down the pike if they're 60 years old, because they may not make it that age. So it's really tough. Of course, then you're older and you may not be able to endure extreme treatments. Cancer care is really, really a tough thing. And again, we had the COVID shots, and a lot of people are attributing all the extra cancer that we're seeing to the COVID shots. We really just don't know, right? Again, our population is getting older. Baby boomers are now becoming seniors, and that's maybe why we're seeing an uptick in cancer. I think we just have to probably worry about younger cancers developing, and I think we have seen a little bit of a trend in that, and we'll just have to research that. But all good points.
Yeah, but it was an interesting topic, and you're right. As we live longer, we live long enough to get cancer. So, that is most of the uptick in cancer for older people is just we're not dying of heart disease in our 60s. We're getting
Right.
cancer in our 70s in some cases, or
Yeah.
So
I
it's
know.
kind of good news in a way, but not
Right.
really.
I mean, I know some older people, like in their 80s, who are diagnosed with cancer and choose not to treat it because
Mhm.
they don't want to deal with the side effects. And, it's a personal choice and something, you need to discuss with your doctor and your family. But good points. I don't see age ever in the headlines when they talk about what causes cancer. So I'm glad you pointed that out. All right. Well, we have run out of time. Be sure to check out Healthcare News for the free market's perspective on all the health news that's going on out there. And the Goodman Institute Health blog. Devon always writes about some very interesting topics if you want to get educated in this space and figure out what is going on. In the meantime, stay well, stay safe, and thank you for tuning in. And we'll be back in a few weeks.